to delegates and all doctors. I'm Yogesh from marketing team, Brownenberg division of Microlabs. And I welcome you for the first webinar on allergy asthma masterclass. And today, delegates are going to talk on how to improve allergy practice in OPD, simple tips, and role of skin prick test and the immunotherapy in the uh, management of allergy. And it's my honor to introduce Dr. Vijay Varad. So Dr. Vijay Varad, he is an allergy asthma specialist in Pune, and he is the owner of Sai Allergy Asthma Eye Hospital in Pune, and he is also attached with the Sahyadri Hospital and Inamdar Multi-Speciality Hospital in Pune. Sir is a member of Allergy Prevention Committee expert from 2019 to 2023, and he is a practicing as an allergologist since last 25 years. Dr. Vijay Varad is a member of Environmental Committee of American College of Allergy, Asthma and Immunology since 2017 to till 2025. And sir is also a speaker of various national and international conferences like IAP, and also various conferences related with the chest physicians, ENT surgeons, ophthalmologists, and IMA associations. So it's honor, sir, to welcome you on this platform. Over to you, sir. Thank you so much.
Please sharing, because then only I can share my screen.
Right, sir.
Thanks, Microlabs, for giving the opportunity and sharing our views. Thanks to Dr. Jayanti Madam for being a faculty in this webinar and the series of the knowledge sharing platform. Good evening, all my colleagues, seniors, and those interested in this field. So, since many years, we are talking to the doctors about allergy management, allergy testing, immunotherapy, and all. Only thing is that, like how in diabetes, the patient goes to any practitioners, everybody has a uniform guidance to the patient. And that's not happening in Indian scenario. So that's why many times it becomes very difficult. See, as an allergy specialist, we invest so much time to educate the people and all. When the patient goes to his family physician or practicing physician, some of the ENTs or chest physicians and all, still the colleagues in India don't know what is happening exactly nowadays, how the practice has changed, how the allergens and the potency has increased, and how the severity of the allergy has increased, leading to the allergic march and complications. That's why many times the patients come back to us and they say that doctor has said no need to do the allergy test. That doctor has said it will overcome, the childhood asthma will be overcome, eczema will be overcome. But the allergic march which continues into the body, and in between there can be a dormant stage or window period where the patient's symptoms will be controlled. And again, there are a lot of misconceptions in the community. So in this discussion, I will try to give a brief on that, because two speakers are there and we have a limited time. So I will be specific about that part. Why allergy? Because as I mentioned, the lifestyle. See, previously the farm dust, the cow's dung, they were as a anti-allergic things. So even the hygiene theory nowadays, it is mentioned. They say that the children should be exposed to these type of things so that they have a specific Th1 response and Th2 inflammation goes down. But because of the pesticide use, then to reduce the grasses, they are again using the insecticides, pesticides. Change in the lifestyle, the pollutants, the vehicular exhaust, the indoor pollution like the floor cleaners, toilet cleaners, perfumes, so many things. the potency of the allergens has increased. That's why the severity of the disease has increased. You also must be seeing in your day-to-day practice. Previously, the patient used to respond to simple medications. After a few years, the patient does not respond to the same medications, and then you have to give oral and parenteral steroids. That has increased, and most of the time, previously, hardly once in a 6 months we used to have anaphylaxis patients. Nowadays, in a week, I am having at least 5 to 6 patients refer to me for a severe anaphylaxis. Then again, asthma and dilated nasal septum, ocular allergies is a very big problem. In the next slides, we'll see how we have to do that. And 2014, there was a very good review done in India, and it was estimated that COPD is going to be the one of the second death causing disease. And recently, just last week, I was for the one of the itikimab molecule, like the biological monoclonal antibodies for the moderate to severe COPD. I am doing a clinical trial. So there, when we discuss, this is third leading cause of death in worldwide, and in India it is the second leading cause of death. And there is a asthma COPD overlap syndrome. And allergy asthma overlap is already well known. Like amongst the children with asthma, 90% have an underlying allergy. Amongst the adults, 65 to 80% of the adults always get a trigger by the allergens. And because of all these changes and even the food allergy cases, admissions have increased by 8 times. We are seeing so many drug anaphylaxis, so many severe drug allergies. Even 2019, when I had been to the Lebanon, the World Allergy Organization, which is the umbrella of 118 countries where the allergy specialists are working, the novel approaches to the worldwide allergy epidemic, so they have mentioned is an epidemic worldwide. And as I mentioned, the changes in the genetics have happened. Hereditary part is definitely there. Like suppose one parent is suffering, 66% of the children may have that. Both the parents suffering, the percentage increases. One of the sibling having 85%, other sibling, always the sensitization into the body to the allergens goes on increasing. And we can see all these, even the throat problem, tonsil adenoids, open mouth breathing, bruxism, rubbing of the eyes, nose, and all. And then eczema, anaphylaxis, asthma, sinusitis, conjunctivitis, these are increased only. And that's why there are some changes to the concepts. Like previously, the people used to have massage and all. But nowadays, as the genetics has changed, now there are documented studies that even the dendritic cell into the skin, they get stimulated because of the food allergens or dust mites and all. And then the patient starts, once that Th2 inflammation increases, then the patient will have a oral food allergies or the inhaled form of allergens leading to the symptoms. So this potency has increased. And as a practitioners, each and every, like as I mentioned already, the diabetes, how we manage everybody the same way. What are the medications patients are taken? Maybe some Ayurvedic doctor is treating, somebody physician is treating, or patient of diabetic retinopathy goes to the ophthalmologist, or with the neuropathy to the neurologist. Once they suspect it is in diabetes, they always do the diabetes management, sugar management. The same way, as a practitioner, our role is very important that whatever the atopic dermatitis, eczema, or childhood asthma, or gastrointestinal colics, or GERD, 40% have food allergies. Out of that, many of the patients may overcome those symptoms, eczema, asthma, or something. Like we know childhood asthma, 85% of the children, they overcome the asthma. But later on, there may be a dormant period, but they will go into rhinosinusitis, vernal keratoconjunctivitis, dilated nasal septum, obstructive sleep apnea, adult asthma, adult chronic respiratory diseases like COPD, and so many. So even severe asthma leading to the cardiac problems, leading to 30% of the cardiac complications. So these are already a big problem. And so number one chronic disease in children, as well as up to 2023, one third of the Indian population will have a significant allergy. And the misconceptions among the community is that it is a lower immunity. It is not that. It is a hypersensitivity to these allergens like pollens, because of the grasses, the weeds, then tree pollens, then common flower pollens in any of the farms or beside the roads and all. Then animal dandruff, they can travel around 15 to 16 kilometers. The dust mites, 80%, they are into the deep beds, sofas, curtains, deep cushions, everywhere. Then funguses, they are into the deep pockets of the cars. Then we did a study in 1996, in 2006 in Pune, and we found these molds were into the common public bathrooms, in the school bathrooms, we actually took the brushings of 65 asthmatic children. We found significant Alternaria penicillium very common into these places. So these are the things. And very few people, 7 to 8% children have food allergies, and around 1 to 2% of the adults have food allergy. Otherwise, most of the environmental allergens are the 90 to 92%. And then there can be a cross reactivity. Some of the proteins in the dust mite are cross reactive to the prawns. Some of the proteins into different foods. Even cockroach is cross reactive to the dust mite. So there are these things, and then the cross reactive will misguide the patient that the food is allergy. So I will just always give an example to the people, like suppose there is a wall and some leakage always was happening from somebody's bathroom and all, it always continues. One fine day the rains will trigger it. The same way it happens in this field. So there is a misconception in the community and they go for the unnecessarily test. So the next speaker will explain about the testing and all. So I will not go into details. But as I mentioned, Times of India 2014, there was an article and people are scared of cancer, but COPD is the second death causing disease. And there are documented studies recently that there is asthma, COPD, overlap syndrome, and all. So I will give a practical examples. Like this child who used to have a seasonal cold previously, some periocular eczema, now significant severe asthma. He was not controlled with any of the nebulizers, inhalers, and all came to me. We did a testing, it was a dust mites and some pollens and all. This was a young girl, 16 years old. You can see how bad it is affected. She had in between seasonal cough cold, then childhood, she had an infantile eczema is what treated. Now she is having such a bad. We are planning for a dupilumab biologicals now. This was again one adult which had a eczema in the childhood. Now he was having asthma, COPD overlap. The small airways are significantly involved. Her quality of life is poor and she can't go to the morning walks. She can't play anything. She's always indoor wearing so many masks and so many things. This was a young adult, twice operated, once for DNS, once for the cauterization of terminal. The primary allergy was not treated and now having a significant sinusitis asthma. So even there are studies down done like tonsils, throat infections and all. Real-time data is there. Out of that, Th2 inflammation is the primary. Allergy is one of the commonest into that. And so if it is treated, definitely this further sensitization and further progress can be managed. This was a patient from a rural area, recently came to me. One day he had been to some work into the farm and suddenly he collapsed. And luckily, somebody observed he's having a significant different sound into the throat. He was rushed to the hospital. It was diagnosed as anaphylaxis because that he was rushed to the pediatric hospital. That pediatrician, his wife and children are taking treatment from me. So he suspected anaphylaxis, gave adrenaline and all. He was saved. Otherwise, in some of the other places, he must have been diagnosed as a heart attack or something. And if the adrenaline is not given in an early stage, once the multiple organ are involved, then it becomes very difficult. So there are so many cases. Like this was a woman who had a postnasal dribbling, significant cough. She was given inhalers, nebulizers, not having relief. You can see this mucus in the posterior pharynx, smaller over, still tonsillar hypertrophy, posterior pharyngeal hyperplasia, and you can see some bluish black discoloration under the eyes. So this can be managed. So we have to understand the allergy that, as I mentioned, it is a very common disease now, and just symptomatic treatment. Like recently, one of the very well-known pharma company in Allergy, the national head had been to me. He said more than 70 to 80 crore people in India are having levocetirizine because combinations of having fexofenadine, having bilastine, or clorphane, maleate, pseudoephedrine, so many medications there. So many of the people are going into homeopathy, Ayurvedic treatments. So there are many people which are just taking symptomatic treatment. So when the patient comes to your OPD, always keep a questionnaire to the receptionist. Even you can have some flyers, some posters into the OPDs so that the people will have awareness about the allergens, how the allergy presentation is different from top to bottom, leading to seborrheic dermatitis, the rubbing of the eyes, nose, or ears. Then I will give you some practical photographs and all. So these questionnaires can be kept. You may not need to take a detailed history. It can be kept over there. The questionnaire also can be put in on the notice board. So the people always have a habit to read what is there and all. So if they feel like, they will ask your receptionist, okay, these symptoms my child is having, my sister is having, myself having, my mother or father, and then such type of, see, as why the diabetes awareness has increased, because each and everybody talked about that. It took around 35 to 40 years. The same way, if we come together and we start talking about this thing, we'll pick up a lot of patients in the mild to moderate symptoms, and we can treat them much better to stop the severity into the adulthood and complications. So this is a simple allergy questionnaire chart. International questionnaires are there. Accordingly, we have to some our own questionnaires also in Indian scenario. Like, see, if you see the nasal itching, rubbing, watering of eyes, then dark circles, frequent blinking, then upper caries teeth, halitosis, then white coating on the tongue, open mouth breathing, snoring, then chronic cough, repeated cough, nighttime, early morning cough, then uh, runny or blockers nose, skin like itching, rashes, urticaria, swelling of the lips or eyes or genitals, repeated secondary fungal infections, pigmentations, boils, then gastrointestinal like colics, abdominal pain, chronic constipation sometimes, acidity. These are all comorbidities. Then others are like a lot of people have habit, they spit it out. A lot of people have doing this way, this way. So such type of things we have to ask the parents or the accompanying people and keep this medication history. Any of the family member had any of this obstructive sleep apnea, snoring, asthma, always first degree relatives, somebody has that. So this simple questionnaire can be kept. Your time can be saved and you can pick it up so many cases. You can increase this OPD in your practice also. So and then conduct the physical examination. See any obvious signs are there and how we can see this. Like allergic shyness, this bluish black discoloration. A lot of people have misconceptions because of some vitamin deficiencies or not having a proper sleep and all. But now it has been proven that these shiners are because of the venous stasis in the lower orbitopalpebral grooves, pressure on the veins by the edematous allergic mucous membranes, because the nose mucosa, which is connected to the sinuses, to the around the eyes, it is connected through the nasolacrimal duct to the eyes, then nasoocular, nasosinal, nasobronchial reflexes, the nerve connection is there. So these are the basically hidden sign. Dark circles is also one of the allergy signals or hidden inflammation, Denny Morgan folds, this Muller's muscle spasm under the eyes. That also can be because of the rubbing of the eyes leading to the breakage of the capillaries and venous stasis. It can cause that. Then allergic long eyelashes, watering of eyes, discharge, frequent blinking, redness, congestion into the eyes, rubbing the eyes. These are the early signs. Then this open mouth, then allergic salute. A lot of people do. Even the well-known politicians and all, they do this way or this way, sniffing inside in a very big way. Very well-known philosophers I have seen when we listen to them, they go on doing such type of different type of sounds and all. So you can see like normal nose how it is, and it doesn't require anything. Just lift the tip of the nose and examine it. With a practice, you will pick it up. How the normal mucosa and the inflamed mucosa, this is normal. This you can see the pale boggy nostrils, inferior, middle, and posterior turbinate hypertrophy. Then leading to that, one side there is a more hypertrophy. It will push the deviated nasal septum. So deviated nasal septum also can be there. Then this derriere line on the hard and soft part of the nose, because of the rubbing, the fold happens. So this also can be picked up in our practices. Then this facial grimaces doing this way. Recently, I had one of very well-known personality, and when I asked, his 16 years old girl had asthma. Any of in the family member has an allergy or asthma? They said nothing, and he was continuously doing this. I asked, "What are you doing this?" He said, "The ENT surgeon has told me about DNS and to get operated." So he doesn't know that that is a allergy sign. So just lift the tip of nose and you can see the pale boggy nostrils over there, shiny like a pulse. Posterior pharyngeal hyperplasia. So just put a tongue depressor or even the loud taking out the tongue. You can see the cobblestone appearance, like how we see the artificial waterfall in some marriage functions or something. The water is coming and the stones are implanted over there. So the cobblestone appearance into the posterior pharynx. Then cervical lymphadenopathy, which is a very important sign because of the chronic obstruction leading to the rich growth of organisms, the drainage over there. Protruded mandible, tip brasses, upper caries teeth. Don't forget the ears. Always have otoscope, see that retracted gums or some problem over there. Polyps also can be done. And always, if any the patient may be having a rhinosinusitis, conjunctivitis, or even the asthma, don't forget the skin. Always look at the skin. Many of the people I have seen, 50 to 70%, always have a significant dry skin. And when we ask them, they will say, yes, from childhood I am having a dry skin. So that is also one of the signs. Then when you ask about the dandruff, seborrheic dermatitis, they will definitely give you the history. So that also we should pick it up as a practitioner, and we can guide that. And as I mentioned, eye allergy has been a very big thing now. 2017, when I was a faculty review author for the European Academy, now that rhinitis term has changed. Now it is a rhinoconjunctivitis only. And even 2023 asthma guidelines by GINA, they're always the rhinoconjunctivitis. So 2018, the World Allergy Organization has said out of allergic rhinitis, 95% of the people have a hidden ocular allergy, which is underestimated, overlooked, which should be treated faster, earlier, because the keratoconus, because of the rubbing of the eyes, then again repeated eye steroids, having a early cataract glaucoma, it has increased a lot because my spouse, in the next sessions, he will speak on that. We are seeing a lot of 17 to 18 years old children requiring lesser treatments for the keratoconus, requiring a severe damage to the eyes, Hill's ulcer and all. So these are the different type of presentations of these children. And as I mentioned about the ocular allergy also, you have to look for the angioedemas, then periocular eczemas, congestion and all. Don't miss that also. And then about the allergy test and all, madam is going to speak on that, which test better and all. But simply with my experience, whatever the ELISA test, the blood allergy tests are done that are not useful. Ideal gold standard is the most important skin allergy test, because already I'm having the best blood allergy test kits like Immunocap, as well as I'm having the computer resolved diagnosis, the Alex with artificial intelligence also for the food allergies. I'm using since last 1.5 years. These best machines I'm having, but those are only for a very few patients which have a significant food allergy with anaphylaxis. Rest of the other 95% patients, 98%, which don't require a blood allergy test, accuracy is very less. Ideally, the skin prick allergy tests are much better. So we have to individualize the treatment plan according to the exposure of these patients, ask the detailed history, what type of exposure is there. Then we can guide the patients about that. Dust mites, pollens, early in the early part of 4 a.m. or immediately after waking up, the patient is having symptoms. That may be the dust mites. Even the pollens and all, they come through the doors and on the hairs and all, they are falling into the house. In the daytime, they are circulating towards the ceiling. In the nighttime, they come at the inhalation level. So some of the patients in the midnight have a symptoms. That can be because of the down pollens. Somebody has some leakage or dampness in the wall. The spores, they now will be open after the rainy season. So that can be the source. So we have to see for that. We have to guide that. Then again, follow up the appointments accordingly. Always guide the patients properly. Just symptomatic treatment with the inhaler, nasal sprays, and oral antihistaminics or Montelukast like add-on drugs and all, it is not going to be sufficient. Explain the patients properly that once we suspect an allergy, it is always allergy till we don't manage it properly. Only thing in between, there can be a window period, and when the symptoms will be there, how severe the trigger and irritants can be the air conditioners, fan, then foods or cold drinks, ice cream, or weather change, water change, or some paints, the deodorants, perfumes, smokes. They can be just irritants and trigger. So that time the trigger can be there, but in between there could be a minimal persistent inflammation continues, or the dormant stage is always continued. So we should always guide the patients like these are the hidden signs, and you should be monitored properly further also. And again, suppose somebody says he had sudden blackout, he had some giddiness, his hypotension was there, he had some breathlessness after going someplace or having some food or Chinese or something. Always don't forget that. Guide them that you keep a ready to use adrenaline injection. So we don't have a EpiPen and all, but we can have our own Indian jugaad, we can call it, like 0.5 ml or depending on the weight, 10 kg, 20 kg, 0.1 ml, 0.2 ml, 0.3 ml. Adrenaline can be kept in a 2 cc syringe with a needle, and it can be kept in a spectacle case, not to be kept into the sunlight. And the patient can carry once the discoloration happens, then they can change it. Hardly 13 rupees adrenaline is there. It can last around 3 to 6 months also without discoloration. So that way we have to guide, so that once the people understand this doctor cares about us, and then they will have a good adherence to you. So then always keep it updated. So whenever there are any conferences of allergy, any webinars, any talks and all, always listen to that. It's a very vast topic. Still, I am learning after so many years of practice. Then collaboration with the different type of organizations like any like now next month I'm having two talks for the family physicians in Pune. Then I am also having a talk after 15 days on the biological therapies, bendalizumab and all that way. So always associated with the ENT organizations in Pune, we have already had a lot of workshops for the ENTs in Pune. So IAPs and all, then keep a proper record keeping. It's very important. Nowadays, most of the doctors also having a softwares and all. It's very easy in the Excel sheet. The staff, if it is educated, just fill up the things and all. Keep it. It helps a lot for our patients. And then after the once we identify the allergens now, then ask the patients to take simple precautions like bed coverings are there. Then some dietary modifications. Trigger and irritants temporarily we have to avoid like spicy things. People always complain after having banana because these are the histamine-rich foods. So once the already mast cell are hyperactivated and the gut mast cell also can be triggered, there is cross reactivity, and that's why the people have a trigger. So temporarily they have to when the symptoms are there. But the summer season, if the patient doesn't have a problem, he can have those foods. And later on, once we properly control the allergy, we make the mast cells from hypersensitive to normal sensitive. The patient can have the same foods. The intolerance can be turn to the tolerance development. So this awareness also should be brought into then the sympathetic approach is very important. Not only just theoretical approach, but the patient should feel like my doctor concerned about my because many times what happens with the patient wants he's suffering. The other family member may not understand his severity. I have a lot of patients, like even advocates and so many. Even recently, one of the actress had been there. So the family member could not understand her itching. She used to have a lot of itching in the night and all. When we checked, it was the dust mite allergy was there. So whenever she used to get to the bed, so the parents and other people said, no, it is all your just imagination. Nothing is there. So they were not talking about that thing. So always have a sympathy, empathy, and then challenges nowadays is at three levels. One is that community awareness is lacking. Even our own colleagues, most of us are treating symptomatically. But the allergy is a progressive systemic disease. The manifestations in the localized manifestations are different, but it is connected from within and it leads to the further complications. And as our practitioners, our role is to stop that. So that awareness should be there. So like a diabetes, the same way, we should always explain to the patient. So when it happens, it has a very good results. And then collaboration with the specialist. Otherwise, what happens is many of times the lab persons they go to the practitioners, they will misguide them. Some of the practitioners they say we will cure your allergy and we will increase your immunity. It is not a lower immunity. To have an allergy, the immunity is good immunity is required. It is a hypersensitivity or a hyperimmune response. Rather scientifically, we have to bring the hypersensitivity to normal sensitivity. So we should have a uniformity. Otherwise, then the patients get miscarried by so many babas claiming that having so many chain of clinics and distributing the medications. Why it happens? Because we don't have a uniformity in ourselves. So keep a uniformity, explain to them. So allergy management can be made very easy and a proper uniform awareness repeatedly explaining to the patients about the things will help a lot. This is a general one. As today we are talking to the pediatricians also, pediatric allergies require us little bit more attention because adults, when they have a severe allergy, already it is a established phase, late phase, their multiple sensitivities has increased. So then the desensitization and immunotherapy takes a lot of time. While children's, they are in an early stage, and when the sensitization has already started, where hardly one to few allergen sensitivities are there. There, if you identify them and if you manage it, definitely it has a very good results. While managing the pediatric patients, anyway, anybody who is looking at the pediatric patients, always once suspected allergy, guide the patients about the allergy management also, environmental control and all. And that's why to handle these pediatric patients, it requires a lot of patience, properly clinical examination on the mother's lap and all, then required allergy test, not all the panels and all. It's not useful. Even now we can do on the hands also. Madam will explain about that. And then awareness amongst the parents because they are having all misconception about food allergy, but they don't know about the other things. So even before coming to me, since 2011, I am doing a telemedicine. Always we guide the parents in my right time whenever I am having a time counsel them first before coming to me so that what happens ki it becomes more easy. Otherwise, already there is a rush, and if you can't give a time to them, they will be confused. So we always guide them about the allergens, what are the dust mites, pollens. So at least they can have, we guide them about some of the our videos or some blogs and all. So they go on that site and check it. And so they get idea about these allergens because people don't know about dust mites, pollens and all, how they can travel so many kilometers. Pollens can travel around more than 130 kilometers, 65 kilometers. Animal dandruff 15 to 16 kilometers. So that way the people don't know. Pigeon fever dropping 50%, that allergy is common in Pune, Mumbai like city. Few years back, we did a study and I presented a paper in 2017 in International Congress of Pediatric Pulmonology. Then we should have a good education to the parents into the different schools during the COVID and all. I took a benefit of that. We had a lot of lectures to the because people were aware about the online training. So then we have since last 27 years in Pune, I'm having a support group. So where the patients have been already recovered and those are in early stage, we have meetings in our clinics or some different places on different occasions and we guide them. And once they understand, the other patient explain to them, then always put the blogs and then efficient quality care rather than having all advertisers and doing any test and all. The standardized testing and the quality care, the madam will explain about that. Then feedback mechanism is also useful. Insurance coverage nowadays, most of the allergy tests, immunotherapy, even the biologicals like omalizumab, mepolizumab, bendalizumab, which are the monoclonal antibodies in the targeted therapies. In next lectures in advances in allergy, we'll discuss about those things. Continue education to the parents, to the people, amongst our colleagues. Also, suppose you understand this now, you always share with your colleagues also, then it will spread that way. And whenever the food allergies or any drug allergy with anaphylaxis, then EpiPen or adrenaline injections, environmental allergy management, allergy, many of times the excipients, preservatives and all, they have a trigger. We will cover in one of the lecture in the details about that. Then communication, and most important challenge is that about the patients who have misconception that the food allergies and they unnecessarily avoid so many things. Nutritional deficiencies are there. Rather than that, the primary allergy, if we manage, then the cross reactivity and all so reduces. So we have to come together and help the people in a very well. So I will just within 2-3 minutes, I will guide about some of the practical cases, like how in a patients were referred in the late stage and how the complications happened because the early stage they were not managed. As a pharmacotherapy, in short, I will in next few lectures we will go into details. Allergen exposure, then depending on that, the mast cell stabilization and the inflammation control with the specific non-sedative below 12 years, the first generation antihistaminics should not be given. There should be a second or third generation antihistaminics. Even they can be increased up to 4 times, like fexofenadine, bilastine, or even levocetirizine. Levocetirizine all can cause a sedation if it is more. Then mast cells has to be managed properly, and not only by the nasal steroids or inhaled steroids and oral montelukast combination. Along with that, always look for the skin. Use a proper barrier, improve the barrier of the skin. Nowadays, there are very specific probiotics also available and monoclonal antibodies that can be used. So this child had been to me many years back with initially having such type of steroid use and having discoloration because of that. Then another child having an ocular allergy. You can see the draining organ folds, upper caries teeth, and turbinate hypertrophy. And this was a drug to me for the anaphylaxis. The patient used to have a seasonal cough cold and he was in a very life-threatening stage. So adrenaline never was suggested to him previously. You can see the significant papillae into the palpebral conjunctiva. This was a significant ulcerations and all. Used to have a vomiting, GARD and all. You can see the turbinate hypertrophy was significant. This was another young 6 to 7 years old girl with a vulnar keratoconjunctivitis, unable to go to school because of the rubbing of eyes. The children used to bully her. This facial brasses, the teeth brushes, then this open mouth, this you can see the turbinate hypertrophy. This was a young girl with an anaphylaxis. This was suggested a tonsillar adenotomy, but we started treating the allergy management. 70% of the people have a dust mite and mold sensitivity. And within 1.5 years, her adenotonsils got regressed. Very few patients which have a significant obstructive sleep apnea require a surgery. Otherwise, nowadays, the new guidelines have mentioned that if you don't manage the allergy and just operate it, then it doesn't help rather than it damages because early part the allergy goes down. So once you do the proper allergy management, then you can go for the tonsil adenectomy or DNS surgeries or sinus surgery. First, allergy management. Again, this child has to have a seasonal cold and all. You can see the upper caries turbinate hypertrophy. Afterwards, he started having a fixed drug triggered rashes to the paracetamol, NSAIDs and all. So this was also again urticaria patient. You can see how spontaneous urticaria since many months was not getting proper control. This was a young engineering student and used to have a significant terminate changes and all. This was the same child. Later on, at 3.5 years, brought to me because they did not go for the allergy management. Now he had a significant secondary infected eczema. The quality of life was very poor. He used to scratch, bleeding used to be there. Then he was referred to us. So that should not happen. So even when 2019 had been to the Munster University Hospital, I was shocked. Like they are using the monoclonal antibodies so regularly, and the impulse oscillometry test, pheno test, and all they are using so many years. Even the homeopathy was derived in this university only. But before that, the allergy immunology department is developed since many years. Even recently, one of the international speaker I listened, before the AC era, one of the king was died because of the wasp bite. That was diagnosed that time clinically, and that evolution of the science has increased. Then this was a 7 years old child having a severe ocular allergy. We required he was diagnosed severe ulcer, intraocular steroids were planned, but when with the proper management and with the omalizumab looking at the total IG level, we got a very recovery. So there are so many cases. This was a young child which had a typical allergic march and then having a very poor quality of life, required of omalizumab because of the steroids, had cataract in an early stage. You can see the papillae. This was a young child referred from the one of the very tertiary hospital for anaphylaxis. He was admitted over there. They were suspecting a peanut allergy, but it was a dust mite contamination into the peanuts. You can see the long eyelashes. So this way, we have to think about the allergy as a very severe, important systemic disease, not just a localized disease or temporary disease. And just management of the symptoms, we are all doing fine now. But the long-term management and the control of the disease and the further progress and sensitizations over the next few lectures, we will have more details about those things. Today, I just thought, like, as a practitioner, you can yourself improve the OPD of these allergy practices and you can have more patients. And so we combining together, we can really give a benefit to the community. Thanks a lot. Thank you. So shall we take the questions at the end? Yes. So I will like to introduce Madam. So today's another speaker. We have a very well-known senior practicing ENT head and neck surgery for 30 years. She is trained under the Dr. Anand Pendurkar, who is one of the pioneer in allergy in India, and she is practicing allergologist in Ratna ENT and Surgical Clinic, Malleshwaram, Bangalore. Madam, it's my pleasure to invite you for today's session. Please enlighten all of us for that. Thank you.
Thank you. Shall I share the screen, Yogesh? Good evening, everyone. I'm Dr. Jayanti Shastri. I would like to speak on role of SPT and AIT in allergic rhinitis. Sir has, there will be a little overlap with whatever Sir has told. So please bear with me. And being an ENT surgeon, I would like to keep emphasis more on allergic rhinitis. Next slide. Okay, briefly about allergic rhinitis. It's the most common form of atopic allergy. And when moderately persistent or severely persistent, it causes considerable morbidity. It is IgE mediated and it affects considerably significant general population. And children and young adults are the more common sufferers. Allergy can affect any organ or any tissue, but it generally affects the skin and mucous membrane of respiratory tract and GIT. And nose being the entry for all the allergens, it bears the maximum brunt of the assault from the allergens. And it has been estimated that allergic rhinitis is about 10 to 25% worldwide. So nose in allergic rhinitis looks like this, and it's on the left side you can see the normal mucosa, on the right side you can see the inflamed mucosa. In both the pictures you can see like this. It's going back. Okay, what are the repercussions of allergic rhinitis? it affects the normal daily activities, and work and school activities take a big hit. Because of the nasal blockage, or because of the disturbances in sneezing and things like that, there can be sleeplessness and resulting tiredness. It becomes very common, and work performance reduces. It lowers learning and cognitive functions in children, and because of it, the children can develop inferiority complex and consequently depression. This is the most undertreated disease, and because of this, they just come and tell us, see, he has common cold always. So, they are not ready for any kind of treatment. But because of this, disease cascades to the above neighboring organs, that is conjunctiva, paranasal sinuses, middle ear, and lower airways. The eye looks like this in allergy, conjunctivitis, and paranasal sinuses. They can be filled with fluid, or there can be only inflammation, or the lining of the sinuses can become thickened, and the osteometrial complex can get blocked, and patient suffers from heaviness of the head, headache, and things like that. Middle ear, it can cause serous otitis media and consequently the impaired hearing, and intermittent acute otitis media also can occur. Lower airways, it can bronchitis and bronchial asthma are known complications. Main symptoms of allergic rhinitis are sneezing, rhinorrhea, and nasal obstruction. And associated symptoms, as we know, pruritus, as sir explained, itching on the nose, and nasal intonation of the voice, eustachian tube dysfunction causing impaired hearing, and heaviness of the head due to collection of the fluid or inflammation, and vascular headache at times because of nasal blockage, and lack of concentration, and decreased interest in social activity, and finally anosmia because of the inflammation. What is the sequelae of AR? After rhinitis, there can be pharyngitis, there can be laryngitis, there can be tracheitis, bronchitis, and finally bronchial asthma. Bronchial asthma causes significant limitation to life, and it causes permanent remodelation of the smooth muscles of the lower airways. So common aeroallergens are from the tree, pollens from the tree, weed, grass, cat and dog, and house dust mites and molds. House dust mites is the most common indoor aeroallergen. Aim of treatment of allergic rhinitis is to provide relief from suffering, and to prevent development of comorbidities, and to prevent polysensitization. Majorly, the management is with oral antihistaminics, and if it is a simple intermittent allergic rhinitis with not causing a lot of problems to the patient, we can manage with oral antihistaminics and intranasal corticosteroids. Topical antihistaminics can also be given, decongestants, and the other modes of methods of treatment is leukotriene receptor antagonists. Saline sprays are given to clear the mucus and mucus plugs so that intranasal corticosteroids get absorbed well. Sodium promoglycate nasal sprays help in preventing mast cell regranulation. And the adjuvant therapies are adequate hydration, diet low in sodium and omega-6 fatty acids and trans fatty acids, diet high in omega-3 fatty acids, and seasonal fruits and vegetables should be given. Surgery is contemplated only when there is a nasal blockage. Otherwise, for allergy, there is no surgery. Surgery is contemplated if there is a deviation in the nasal septum, or if there is hypertrophic turbinate which is not responding to intranasal corticosteroids, or if there is polyps and other things like that, surgery is required. And yoga and breathing exercises are very excellent adjuvant therapy. Like breathing exercises like Anuloma Viloma go a long way in helping the patient. And relaxation techniques, because allergy is a psychosomatic disease, and any tension, any pressure can increase allergy. So relaxation techniques like meditation is a very good thing. And last but not the least, allergen immunotherapy, which is known curative, this one for allergy. So the best course of action for allergies would be find the causative allergens and avoidance of allergens. But avoidance of allergens is easily said than done. So what is the next option? Best option would be allergic immunotherapy. But for allergic immunotherapy, first of all, we should know what are the specific allergens that are affecting the patient. For which, of course, we have the blood tests like we can serum specific IgE tests, which are quite accurate in detecting this allergens. But one thing is they're very expensive, and for some allergens, the IgE measurements are not available. So, what is the best option? Gold standard is skin prick test. It's the most useful single modality for demonstration of IgE mediated underlying mechanism in suspected allergic cases. Its interpretation utilizes the presence of the cutaneous reactivity and also the degree of cutaneous reactivity. We use this as a marker for sensitization. Relevant allergens are introduced into the skin. Mast cells degranulate. Histamine and other mediators are released, and wheal and flare response is seen. This is briefly what the skin prick test is. But how do we? Yeah, the history is that in 1926, Lewis and Grant started this, and it was perfected by Jack Pepys. It is a reliable method to diagnose IgE-mediated allergic disease, and it has been shown to correlate better with symptoms than intradermal testing. It is minimally invasive. It is not very expensive. The results are immediately available within 15 to 20 minutes. We read the results. It has good sensitivity and specificity. It can also be used to test certain less common allergens like certain fruits, etc., where SSIgE measurements are not available. The common indications for SPT are allergic rhinoconjunctivitis, allergic rhinitis, allergic conjunctivitis, allergic rhinosinusitis, asthma, atopic dermatitis, food allergy, and venom sting reaction. There are certain uncommon indications, selected cases of chronic urticaria, and allergic bronchopulmonary aspergillosis, cases of migraine, which suggestive of which have comorbid allergy symptoms, and a few cases of Meniere's also, which have comorbid allergy symptoms. The other indications can be community for the community, like screening for predisposition to develop atopic disease, and also epidemiological studies to study trends and regional differences. And in children, for repeated testing to determine if any new allergen sensitization has occurred. Allergen selection. First of all, before we select the allergens, we should know what are not allergens, what are not considered as allergens. Food additives, coloring agents, preservatives, these are not allergens. And there are some allergy triggering factors like suspended particulate matter, deodorant sprays, perfumes, atomizers, agarbatti, smoke, kitchen fumes, dhoop, camphor, cigarette smoke, etc. These are just allergy triggers and they are not allergens per se. And some patients come and tell us, we were exposed to dust on the road and we were exposed to the dust from the construction site, and hence we developed allergy and things like that. But truly speaking, this dust they are not allergens. They are just allergy triggering. But actual allergen is the house dust, which contains house dust mites. And most of the house dust mites are present on the mattresses, because mattresses provides them a warm, cozy environment to multiply. And also, humans shed about 1/5 ounce of dead skin every week. And these dust mites feed on them and thus multiply. So one best method would be vacuuming these mattresses and sofas and things like that frequently does help in preventing, reducing the allergic symptoms. So allergen selection, emphasis should be on the airborne allergens, both indoor and outdoor, because nose is the entry for most of the allergens. All pollens, all fungi, the 3 dust mites like Dermatophagoides terricinis, Farini, and then Lomia tropicalis, and insects like ant, cockroach, moth, etc., and which are commonly present at home. And food allergens should depend on the history and clinical suspicion. And pet allergens like cat and dog, birds allergens like pigeons droppings should be used for allergic testing. Selection of the case. This is also very important because mild and intermittent symptoms, many a times patients may not be very interested in getting an allergy test done, and this one. But and if we do a SPT and subsequent AIT in them, the benefit may not be so very perceivable. But still, we should counsel the patient, and we should keep them under constant follow-up in case the allergy becomes moderate or severe. So in moderate persistent or severe persistent, which impacts the quality of life, SPT is a must. And in very young and very old patient, the response pattern may not be that satisfactory. It's supposed to be about 25 to 30% less than the regular in the proper age group between 5 years and. So SPT better to be done above 5 years, but if it is a very bad case, which definitely requires, it can be done below that or below 5 years also. What are the contraindications for allergy? Severe dermographism. The picture is seen in this one. In severe dermographism, it becomes very difficult to do an SPT. And in an uncooperative patient, and patient who cannot stop taking immunosuppressive medications, mentally unstable patient, and any active viral infections like influenza, etc., and unstable severe asthma. These patients, it is a contraindication. There are some relative contraindications like mild dermographism. Here, SPT should be done with care, not giving too much of pressure on the skin and things like that. And in pregnancy and active HIV infection, active viral hepatitis, and patients taking beta blockers, the problem here is first of all, it may reduce the wheal size also. Other thing is that patients with beta blockers, they are resistant to the treatment for anaphylactic reaction. So we have to be very careful with them. So, and if a patient is taking UV radiation for any skin disease, then also we have to think and do the SPT. So first of all, we have to appraise the patient of the procedure. We have to spend quality time with the patient, explain the details of the SPT, take an informed consent, and patient must be made to understand that SPT is a window of opportunity for cure. And patient should be detailed that SPT is only a diagnostic tool and not a treatment by itself. Are there any adverse effects? Very little. Sometimes allergic reaction and some transmission of infections, if sometimes because of the skin, if there are any skin infections, and syncope. Some patients who are very tensed about it, they can develop syncope. So best to do allergic test in a supine position when we are doing on the forearm, or in a prone position for the back. So some patients may develop some headache, and very rarely anaphylaxis. So if there is, for whatever reasons, we have to keep a medical emergency kit ready for anaphylaxis. What are the precautions to be taken? Caution to be taken if it is the allergic season for the patient. And patients on beta blockers and ACE inhibitors, as I already said, and drugs that reduce the response should be stopped for a while before SPT. And topical moisturizers should not be used before SPT. SPT should ideally be performed at least 4 to 6 weeks following a systemic allergic reaction. So drugs which interfere with SPT and when to stop, I have just put a list of it. Short-acting H1 blockers, 3 days. Long-acting H1 blockers like Atarax and all that, 7 days. Long-acting H1 blocker like cetirizine, 7 days. Fexofenadine, 5 days. And local, that is azilestine, topical antihistaminics like azilestine for 3 days. Topical steroids for 21 days. INS, that is intranasal steroids, inhaled steroids, 5 to 7 days of oral prednisolone, and monticulas, they need not be stopped. Depot steroids for 90 days, it should be stopped. And omalizumab, which is a biological, it should be stopped for 6 months before we do an SPT. Tricyclic antidepressants for 14 days. Benzodiazepines for 7 days. Chlorpromazine for 7 days. Ayurvedic and homeopathic drugs, if they are labeled, they can be stopped for 7 days. Otherwise, they should be stopped for a minimum of 28 to 30 days. Allergen extract. This should have batch-to-batch consistency of protein nitrogen unit content. Only one, when we are doing the test, only one vial should be opened at a time to avoid cross-contamination. Glycerinated allergen extracts of 1:10 concentrations are commonly used because It has a good shelf life. Histamine 0.1% is used as positive control and saline as negative control. Individual testing allergens should be used instead of mixed allergens, and it should be stored in the temperatures between 2 to 8 degrees centigrade. The SPT procedure, patient is on a reclining chair or in a supine position. If it is done on the back, patient should be on the prone position. Materials necessary are allergen extracts, negative and positive controls, prick devices like lancet or a 23 gauge needle, 1 to 1.5 inches long, skin marking pen, isopropyl alcohol to clean the skin, wet wipes and dry wipes, timers, magnifying lens, reaction measuring plastic transparent template, case sheet to record the results, and of course, emergency medical tray. So SPT solution tray looks like this with solutions placed and coded with code numbers. And the numbers are written on the forearm like this, as shown in the picture. And a single drop is this one is placed on the forearm as shown. And in the center of the drop, we introduce a lancet perpendicularly. It goes 1 millimeter below the skin, and it stays there for a second, and then we remove it. And similar thing is done for all the allergens. So the interpretation is a wheel size same as that of the positive control is considered as 3+, and reaction equal to negative control is negative. Grading between plus and 2+ is between positive and negative controls. For any response greater than 3+, a plus is added for each doubling of average diameter. What do I mean by this? If the wheel is suppose an ovoid wheel, we take the 2 longest diameters and add them and divide by 2. And if that is double that of the positive control, then 1 more plus is added here. So significance of SPT is that specificity is 70 to 95%, sensitivity is 80 to 97%. So SPT is a wonderful tool for us to find out the specific allergy. So once we find out the specific allergen, we have to think of allergic immunotherapy. Johnstone and Dalton were the first to recognize the concept that allergic immunotherapy could slow the atopic march. So allergic immunotherapy is administered in gradually increasing doses of allergen vaccine. It reaches a dose which is effective in ameliorating the symptoms when subsequently exposed. Mechanism of action of allergic immunotherapy is it causes very early desensitization and modulation of T and B cell responses. It also modulates the related antibody isotopes and migration of eosinophils into the tissues, eosinophils, basophils, and mast cells into the tissues. And skewing of allergen-specific effector T cells is the key event in the development of healthy immune response to allergen. Sir was just now telling TH2 and TH1 status. It changes the TH2 status to TH1 status. That is the normal immune status. So AIT is the only available curative tool. It alters the course of allergic disease for good. It impedes the onset of asthma in cases of allergic rhinitis. It impedes polysensitization. It's capable of providing medication sparing effect. That means the medication we can reduce the medication as the treatment goes on. And benefit of AIT continues for a long tenure even after concluding the therapy. And long-term protective benefit against development of various other allergic conditions will be reduced, will be there. So for a successful sublingual immunotherapy, a proper diagnosis, good quality allergens, compatible and proper combination of the allergens, and compliance of the patient is very much required. So in conclusion, SPT done with good quality antigens is the best diagnostic option. SPT offers both qualitative and quantitative measure of an allergic activity. It is hardly an invasive procedure, and combination of SPT and SSIgE offers a very good diagnostic support. And SLIT, that is sublingual immunotherapy, is the best option of treatment, and it should be given for 3 to 5 years. Thank you.
Madam, for a really enlightening on the very important topic, which is underestimated in Indian scenario. And there are a lot of misconceptions about the allergy testing immunotherapy. So you really had a very simple way and to explain to the people like what precautions to be taken. So there are some questions actually. So we'll go for that. One question was that what are the preventive measures? Like some say morning walk is helping to cope up and reduce allergy because early morning will have more allergens atmosphere. So, madam, can you guide on that?
Sir, can you please repeat the question? I couldn't see the question.
Yeah, what are the preventive measures? Like some say morning walk is helping to cope up and reduce the allergy, and but actually the in morning the allergens are more in the atmosphere.
Yeah, it depends on the what allergy, what the patient is allergic to. If a patient is not allergic to the pollens that are there in the atmosphere in the morning, they can easily go for a walk because walking does help, exercise does help in reducing allergic reactions. So
Yes.
it depends on that, what exactly they are allergic to.
Yes, ma'am. Only thing is that in Pune or Bangalore like cities and all, even that winter smog, it is not a fog, actually it is a smog. So
Smoke.
even it traps the pollutants also like vehicular exhaust, construction dust. So while having a walk, they should have a proper mask so that it prevents these pollutants also to enter and have symptoms. So as you rightly said, if there is no pollen allergy and all, but these are added on effects of pollutants, they should use a mask. That's very important.
Okay.
Again, one more question is there, importance of the local allergic rhinitis.
Importance of local allergic rhinitis?
Yeah, I think he wants to ask that because some of the patients, we don't pick up on the test like skin prick allergy test or something. The sensitization in the mast cell bound IG is not there, but the patient have localized allergic rhinitis, that is a localized pollinosis. Basically, just the terminates get sensitized, but the systemic specific IG is not formed in these patients.
Yeah.
So these patients, then the nasal challenge test should be done. That is not so routinely done in India,
Correct.
but outside in European countries and all, there are specific sprays for that with the allergen extracts. So that I think he wants to say that. So those cases, they don't require a systemic.
SPT is not required.
Yeah, SPT, if it shows a negativity, then these patients should be treated symptomatically only, I think.
Correct.
So nasal sprays and oral antihistamines and all also can benefit. Definitely. So again, one question is there, is doing IG an absolute eosinophil count useful, or should we just do the skin prick test?
Total IG is, it can just guide you whether the patient is allergic or not, depending on the higher concentrations of total IgE. But otherwise, it's not of much use. And absolute eosinophil count, no, it's not of much use at all. Only for skin prick test is the best.
Yes, ma'am. So basically, to diagnose the allergy, it's mostly a clinical diagnosis. And suppose we want to identify the allergens, what precautions to be given to the patient, then the specific IgE skin prick test is the gold standard. And some of the patients with a severe asthma, where the standard therapy is not helping these patients, and these are some phenotypes like eosinophilic type of asthma or significant nasal polyps requiring repeated surgeries. Those cases where we want to give a monoclonal antibodies, a specific target therapies, their cases only, these counts and all, they help us because total IG in Indian scenario may be higher because of other things also. Even the eosinophil count because can be because of the tropical eosinophilia, eosinophilic esophagitis, or even the parasitic infections and all. So we have to always weigh the things and we have to ask the detailed history. So to diagnose it, always skin prick test, but some of the phenotypes and all that can be useful when we suspect for the third line treatment. Suppose we want to give this target therapies, biologics and all, then it can be useful. Then one question is importance of probiotic in changing pathophysiology of allergy. So it's very interesting
Importance
question.
of
Actually, yes, there are a lot of studies now going on. Now future therapies are on probiotics as well as biologics as a target therapies, but still are only like 4 years I was involved with the World Allergy Organization Allergy Prevention Committee on the food allergy and atopic dermatitis. There are always two thoughts. So one thought says ki even during the pregnancy in the third trimester, these high risk patients of the families, if the mother is also supplemented with some specific research probiotic, it will help to reduce the severity of the allergy. It doesn't prevent completely, but it will reduce the severity. The same way, still there are some studies happening even in the NECs, necrotizing enterocolitis, or to prevent the severe food allergies and atopic dermatitis, to reduce the gut inflammation and all. But still there are not a proven studies for the allergic rhinitis asthma. So, but there are some respiratory probiotics, we call it. Worldwide, they are available even in USA, Europe, and even India also nowadays, like Lactobacillus bifidobacterium, that way. So, but I think the more studies are required because our microbiota, our population is different. Then only we will know the proven effects. In practice, variations can be there. Those are again still under trials only. Yeah. Then, how long does it take for airway remodeling to occur in allergic rhinitis?
that exactly, even I don't know, but even I don't know about that.
Actually, basically, still at present, I also don't know exactly how much time and all, but there are documented studies that it is a one airway, one disease. Even not only one airway, one disease, I will say it's a one mucosa, one disease from nasal mucosa, which is connected to the sinuses, to the eyes, to the ears, to the throat, tonsil adenoids, to the lungs, and allergy as a systemic disease. So the remodeling definitely happens. There are studies done with the bronchoscopy, biopsies, and all. If it is not controlled properly, and if there are repeated attacks of inflammation, the remodeling definitely happens. But how many, after years, how many years it takes and all, still there are no documented. There are always variations. Some of the patients, practically, we have seen very fast progression because it's a genetic disease. So each and every patient is different. Somebody has a one or two sensitizations, having a very severe allergies, and some of the people have multiple sensitivities, but still they don't have a severe allergies. The same way, here also, the each and every patient is different depending on his exposure to the environment, depending on the passive smoking, the chulas and the firewood burning, or so many things are there. So that way it happens. So it cannot be for the general population or a specific. It depends on the epidemiology, or social status of the patients also. Role of some probiotics in allergy, how effective? I think the same question has been repeated. So basically, the probiotics is definitely a future. There are the gut lung axis, the gut brain axis. So many things are happening. Even the gut eye axis also. So even I am also using in some of the severe ocular allergy patients, periocular eczemas and all. We have found good results, but it all varies from patient to patient. So we require more studies and practical use. What is the criteria for call? It has an hypertrophic inferior turbinate clinically and radiologically. Will you please guide on that?
Yeah, can you please repeat the question,
Yeah,
sir?
it's a
Sorry.
criteria for hypertrophic inferior turbinate clinically and radiologically.
What's the criteria?
Yeah.
Okay. I mean, clinically, we can see that the how much space is there between the turbinate and the septum, and then take a call on whether this patient has a hypertrophic turbinate or not. So we grade it as mild, moderate, and severe. And
Yes,
when the turbinate is almost touching the septum, it is called a severe hypertrophy of the inferior turbinate. And otherwise, it's graded like that. And radiologically, yes, CT scan is the only this one which can help us make out how much turbinates are hypertrophy. And yeah, it also the similar this one, how much of space is there between the turbinate and the septum in a axial cut. That is what we measure to see whether it is mild, moderate, or severe.
Yes, ma'am. Absolutely. And as you mentioned, still in worldwide, like those developed countries where a lot of research is done, and the university hospitals which are using all these anterior rhinoscopy, then rhinomanometry, acoustic rhinomanometry, and all. But still in India, they are not used everywhere because the people are not aware about that. Patients are not uh, ready to go for so many tests. It's already difficult to do the skin prick test, and they don't go for so many investigations. So clinically, we have to go, and clinically, it is very easy to do that. If you go on doing the analysis in our practices day to day, we start examining. Definitely, we will know that which are the hypertrophied and which are the normal terminates. And always there has to be a clinical presentation also.
Yeah,
So
maybe
that way,
some
clinical.
cold spatula test also helps. Cold spatula test that helps.
That is also there clinically. Yes, yes, definitely. Cold spatula test. Yeah, as you rightly. So these are there. So we can do that. Then can a short-term steroid therapy develops a resistance to allergy?
No, I don't think so. No.
Actually, first, most important is that steroids are for a very severe allergies and life-threatening allergies or severe asthma and all. They should not be used, but in India, they are overused, abused, self-medicated by the patients also because it gives the immediate relief. But that is just to control the temporary inflammation. It has a multiple actions. That's why the patient have a immediate relief. But long-term wise, definitely, then the safer medications don't act like add-on montelukast or the molecules like third generations antihistaminics. They don't work on these patients if they are repeatedly use the steroids. And because of that, the systemic immunity goes down. Secondary infections in these patients increase, fungal infections and so many things. We have already seen during the COVID because of the repeated steroids as well as the repeated steam inhalations. Even now, the topic has come. So the steam also should be utilized very judiciously whenever there is a significant block or sinusitis, which is causing a significant one, not as a routinely for the normal cold or smaller symptoms. So such type of things should be used very judiciously. Definitely, steroids are the life-saving medications, but they should not be used so repeatedly. Rather than that, the safe antihistamines, safe anti-inflammatory medications, or where the steroids are required repeatedly, then patient should be put on the biological therapy, monoclonal antibodies. But before that, first most important, which is not practiced, is the allergen avoidance measures or environmental control. That should be guided to the patients before the steroids and all. Could you please clarify on some patients telling they start sneezing once they touch water early in the morning? Yes, actually,
That
madam, will you like to say something?
that's actually basically sometimes cold and even air conditioner can trigger some kind of an irritation in all already atopic individuals. So that can trigger this one. Not touching water really, it is not true. I feel it's just that mental makeup also of the patient that it can.
Yeah,
That's what I
you
feel.
are absolutely right. As you said, these are the basically they are just the triggers and irritants.
Yeah.
So there are multiple triggers and irritants. Somebody by touching by the hands to the cold water or immersing the legs into the cold water, somebody gets a trigger by touching at the nose also. One young girl was there to me. Suppose somebody used to touch the nose or at the forehead. She used to sneeze a lot. So it was her irritation. It was not a primary allergy. We started managing the primary allergy. It went down very smoothly. After 2 months now, she doesn't have any problem. Otherwise, last 3 years, she used to have a lot of problem with that. So weather change, so many things are basically the irritations, AC, cold air. Some of the patients, they complain like even after opening the window of the car or the child is put to the window, immediately he starts sneezing. So that breeze and all that just triggers it. Or sometimes there can be a pollination, more pollens, and they can trigger it. But these just cold air and all, they are the irritants. So the irritants already the patient where the primary allergens has caused the sensitization, the mast cell hyperactivation happened. There, these foods and the coloring agent, paints, deodorants, even the frying oils, the smoke of that, or the
Perfumes.
smell, they are the irritants basically. Yes. One question is that can patient taking homeopathic or Ayurvedic treatment for allergic rhinitis go for immunotherapy?
Yeah, they can go for immunotherapy, but for SPT, we need to stop the drug for, as I said, for about 28 to 30 days to stop the drug and then do an SPT and find out the specific allergen and then give AIT. Along with that, if they want to take Ayurvedic medicine, they can take. But we don't know the reaction between whether that Ayurvedic medicine is going to cause any this one. For this, we have no idea about that.
Most important is that, like as I said, I went to the Munster University also, and I discussed with some of the homeopaths over there also, because homeopathic treatment started from Germany only. So, but there, all the Ayurvedic and homeopathic doctor also, they always refer the patient to allergy specialist. So, symptomatic management is different, but this is a specific disease. This is a hypersensitivity or hyperimmune response. It is not a lower immunity. And most of the patients are misguided that we increase the immunity of these patients and we cure you. It is not that way. It is a hypersensitivity. So symptomatic relief is different. Even some of the patients having a cold bath, I have seen some patients, they say after having a cold bath, after having a swimming, after having a pranayama, yoga, I had a relief. That temporary relief will be there. But the newer sensitivity formation into the body, the minimal persistent inflammation, which is continually underlying without any much symptoms, it continues. So immunotherapy is the only disease modifying therapy. So selection of patients, immunotherapy can be given for all patients, whatever treatment they are taking. They may be taking homeopathy, Ayurveda, electropathy, Unani, whatever, doesn't matter. Or allopathic. Immunotherapy does not, it acts at the specific Ig level, forming the IgG1, IgG4 antibodies. It's very safe and that can be taken, definitely. Then does morning walk act like a immunotherapy?
No. No, it does not. It's an adjuvant therapy.
It
Adjuvant
cannot,
therapy.
because, yes, ma'am.
It's an adjuvant
Morning
therapy.
walk and all, see, yes, ma'am. Actually, depending on the season, see, suppose a person who is taking a morning walk in the rural areas, it is different, and taking a walk in the urban areas in the winter season when there is a smog rather than the fog, it is a smog. So that way it affects any exercises, any, most of the time they help these allergy patients, because once they exercise, there are endorphins, they control the inflammation into the body, feeling like the patient is also happy after the exercise. So that happiness, it also brings down the inflammation. There is a vasodilation which helps these patients. So there are many things, the circulation improves over there, but that is temporarily. The long time wise, it does not help. Could you please elaborate on effectiveness of posterior nasal nerve section in cases of allergic rhinitis? Ma'am, it's your question, please.
Posterior what? Nasal?
Nasal nerves.
Sir, elaborate
section.
on posterior nasal?
Nerve section.
Nasal nerve section. Okay, I think he's asking about Vidian neurectomy.
Yes.
No, Vidian neurectomy is normally not for allergic rhinitis. It is for vasomotor rhinitis. Vasomotor rhinitis, it helps. Vidian neurectomy helps, but not for allergic rhinitis.
Yes, that's true. Now, is neti helpful? Nasal wash.
As I already said, yoga and nasal breathing and breathing exercises does act as an adjuvant therapy for allergy. So neti also can clear the mucus and other things from the nose. Yes, it might be a little helpful as an adjuvant therapy.
Yes, ma'am. Actually, in my practice also, I am routinely using, even very smaller children also now ready to use nasal dousing solutions are useful. About 12 years, 14 years, the nasal wash now, not neti, even the improved variety of that with the proper bottles which have been studied, having a good deep wash into the nose. It also helps. Only thing is, most important is that the sterilization of the water to be done. The boiling should be done at least minimum 10 minutes. Then lukewarm water added on that salt. can be used, not just
Clean
filtered water and just lukewarm and use it. Always boil it. It has to be sterilized properly. That is very useful. How long we can give Montelukast bilastine? There is no restrictions. It depends on the seasonal exacerbations. We can use it for 1 month, 3 months, 6 months also. Some of the patients, they require for a longer period also. I have used for 3 to 4 years also, no problems. Very safe medications. But only thing is Montelukast is an add-on therapy when the antihistaminics in a higher dose, they are not working, or moderate to severe persistent allergic rhinitis or rhinosinusitis and all, they are used. These combinations are much useful in rhinosinusitis and rhinoconjunctivitis very well, and can be given for a longer period also. But always, because otherwise the patient will run away from another doctor. So always check that depending on the exacerbation, during that time you use for a 3 to 6 months or 1 month and all, then again keep a gap. Again, if required, then you can add on that way. And explain the patient that it is a chronic disease. So one course of will not going to alter the complete disease progress. 1 or 2 seasons has to be managed properly. And along with the allergy management, like testing and avoidance measures and immunotherapy and all, they will help that. So it can be given a long. In 2013, when we had been meeting in Hyderabad, and John Price from Mexico had been there, and Papaticolo from this one, and they said they are using since many years, so they can be used very well. How many days you can use steroids nasal spray, ma'am?
Steroid nasal spray can be used for a month or 2 months. There is no problem. Yes. Actually, even it can be used for 6 months also. There is no problem with this.
Absolutely. Even some of the very severe patients, and if they require for a longer period, also can be used. Only thing is, depending on the seasonal exacerbations, again, suppose in the summer season, most of the patients don't have much problem. So during that time, it can be stopped, or it can be kept in an alternate day also, depending on that, or like twice a day initially, then once a day. Depending on that, we have to manage it each and every patient.
It is individual, this one,
yes,
for how long.
So
and
basically,
also
customization.
We can start the steroid spray about a month before the actual allergy season for the patient starts. So that they will not have triggers of allergy and things like that. So it's all tailor-made for the,
absolutely, customized or tailor-made.
Customized, yeah.
But it can be used for a longer period also. Practically, specifically nasal polyps or significant obstruction, blocked nose patients can be given for a longer period also. Only the administration is very important. It should not be at the septum level. It should be away from the septum towards the terminates. That simple things also should be in next lectures. We will have the practical demonstrations and all, how the people should use that. We can run some videos and all, so that the people can understand. Is there any permanent cure of allergy in COPD patients with increased IgE and positive skin prick test? What is the treatment modality? So already, as madam also said about that, the disease modifying therapy is proper allergen desensitization, immunotherapy, or allergy vaccine shots, or tolerance development. COPD patients, when there is a ACOS, asthma COPD, where the asthma allergic component, if it is more, then it can be used. But the only COPD patients, the allergy does not have a role into that. Trigger can be there in some of the patients, some allergens. The avoidance measures or environmental control can be guided to those patients. Specific IgE increase, not a total IgE. Total IgE or eosinophilia, like as I said, I am doing a trial for itiquimab. So those COPD patients where the eosinophil count is higher, we are using itiquimab and we are having a good results. That more research will be required for that. Then basically permanent cure, as I mentioned already, it's like in diabetes, blood pressure and all. Possible cure can be there, but not a permanent.
Near permanent.
Basically, this disease depends. How diabetes depends on the patient's exercise, the diet, stress. The same way, allergy also depends on the patient's lifestyle, the exposure to the allergens, what precautions the patient is taking, which area he is staying, and allergy part will be taken care of. But the pollutants, the construction dust, vehicular exhaust, their exposure, the comorbidities. So depending on that, but definitely the possible cure or the near permanent cure can be achieved with the proper guidance and all. Not going to the laboratories and all, the person should be referred to the proper qualified allergy specialist the standardized allergy test. Otherwise, then it has a miscommunication. A lot of advertises are done and all, they are miscommunicating. That's why this science is not developed in India, because so many people are without qualifying, they are practicing and they are misguiding the people that way. For how many days can we give fexofenadine or steroids intranasal? So already steroids we have discussed about that. Fexofenadine, even third generation antihistaminics can be given for a longer period also. But most of the patients after the history will identify seasonal exacerbation. Most of the patients have seasonal exacerbations. So during that time only they require, as a suppose the patient doesn't have a response to the intranasal steroids, and if requires an add-on therapy for a longer period, then we can give it. Otherwise, many of the patients in an acute phase exacerbations with the fexofenadine and the second and third generation antihistaminics, we control the symptoms. Later on, we put the patient on the intranasal corticosteroids. The patients show a very good response. So that also can be worked for them. Anti-allergic medicine can be given for allergic rhinitis in children, and duration. As I mentioned, most of the children with allergic rhinitis have a seasonal exacerbations. There, we can use during that season, even as Madam said, before the season starts also, at least 10 to 15 days before, we can have a nasal wash and nasal sprays. And then as the patient starts showing symptoms, we can put the child on our anti-allergic medications. We can use during that 1 month, 3 months and all, no problem, even up to 6 months also, very safe, no problem. Even Montelukast is an add-on drug, because that is the only safe where the steroids are used so much in India. Rather than that, Montelukast is much better. We are using since so many years. Whatever the people talk about the black box warning on, till my more than thousands of patients, only one child I saw around 12 years old with some behavioral disturbances and all. Recently, when during the one of the international webinar, one of my counterpart from USA, they also said that in USA, though, a lot of people have known about that. The community, the patients also knowing about black box warning and all. So they always ask them. So they say, ki, nothing to be worried. If your child is showing some changes behavior, then you stop it. Otherwise, there is no need to stop. And in our practices also, you are using so many years, we don't found any problem with the Montelukast. So it can be used depending on the moderate to severe intermittent persistent cases as an add-on therapy. And specifically, it is a very good drug for 1 year one disease, or exercise-induced asthma, or such type of things. And so there we can use very well. Then duration, as I mentioned, it can be used for a longer period only. Very few patients require throughout the year. Significant dust mite or perennial allergen sensitivities, those patients, they may require for a longer period, but those patients always guide for the avoidance measures like dust mite proof covers, or putting the beds and all into the intense sunlight. And desensitization also should be, because otherwise this patient symptomatic control will be achieving, but the dust mite sensitivity will continue with the multiple pollens and all, and then later on the patient will have a deviated nasal septum, sinusitis, oral keratoconjunctivitis, or other complications. So then the desensitization to the immunotherapy for the dust mites and all should be used. What if the causative allergen is cow dander, patient's occupation is dealing with cows on a daily basis for milk production, what advice should be given to such a patient? Practically, I had 6 to 7 such type of patients, cows or buffalo dander allergies. Even recently, one adult is there. So he has a typical farmer eczema. Whenever he has that milking, he starts developing that, and very significant. So there are some cases where they develop that. There, then we have to first try to avoid that. They can use the gloves and all during handling the things, or some overcoats and all. And as soon as they finish the work, change, and then only come to the house or other places and don't sit over there. So they can avoid whatever, use the mask also that way. And with the specific symptomatic treatment with the nasal steroids and all, or localized barrier improving moisturizers and anti-allergics and all, the patient is much better. Then they can be practiced. But otherwise, very few patients. One patient, I did a desensitization also. Whatever the crude method way, we don't have a standardized one for that. but that also showed a very good response. So we are customizing the therapies, and the future will be definitely more into that. Ma'am, would you like to add anything?
Nothing, sir.
Yeah. So again, the same question about the nasal steroids. Contents of nasal dousing solution. It's basically the normal saline only. There are hypotonic, hypertonic, and isotonic saline solutions. So yes, ma'am, please, will you like to add?
No, I just said saline, nothing else. Nothing.
Yeah, yes, ma'am. So there are, depending on that, so infants and all, there are hypotonic solutions. About toddlers and all, there are normal like isotonic and hypertonic. I think you ENT people are more using for post-operatives and all, because we
Initially,
don't
post-operative period.
yes, because we don't use as an because that can irritate again the mucosa. So only post-operative. So when can we use a systemic steroids? See, basically systemic steroids, as I mentioned, it is a life-saving procedure. Specifically, anaphylaxis patients, the drug of choice is a adrenaline intramuscular. But to stop the biphasic reaction, after some time, the patient can have a second episode. There, the steroids have a very good role. Then, severe asthma, where the patient is having a compromise and is having a life-threatening episode, or very severe, which is not getting control with the nebulization with oxygen and all, then we can use the oral or parenteral steroid depending on that. Or angioedemas, where the patient does not respond to the increased dose of the antihistamines, like 4 times also, then we can use such type of medications. So there are all like tailor-made or customized. Depending on that, we have to use it. And again, some of the patients with eosinophilic esophagitis, then significant food allergies and all, it can be used to relieve the symptoms that way. What are the basic investigations we can do for allergic rhinitis? Ma'am, will you revise it?
Basic investigations?
For allergic rhinitis.
Allergic rhinitis. Okay, regular total blood count and things like that. Routinely we do it. And of course, some CT scan of the paranasal sinuses we do. And sometimes I do take the help of total IgE count to see, just check if there is any very high counts or anything of that sort. And then basically allergy is diagnosed with the history and local findings, and then planning for SPT. That's all. Not too many investigations are not required.
Yes, ma'am. Absolutely. Like it's like a suspecting a diabetes and not doing a blood sugar and analyzing so many things. The same thing is happening for allergies, including allergic rhinitis in India. Rather than doing other tests, ideally, first should be the skin prick test, because that is the only one which will help the patient specific way. Rest of the other investigations, they are the second line investigations where suppose we want to rule out the other causes, or if you want to add on the biologics and all, then only they will be useful. Otherwise, they don't useful. Indications of bilastine and fexofenadine use. So basically, as Madam also told in her speech, and myself also I talked about that, symptomatic relief like itching, rhinorrhea, inflammation, whichever part of the body, from the sinuses to the nose to the asthma, with plain only asthma, there are inhalers and all require nebulization. But along with that, if the patient is having a comorbid conditions, which many of the patients have that, like itching is also there or eczema also there. Now there the itching to stop, that can be used. So these cases, this bilastine and fexofenadine, they are used. Dr. Pallavi has asked that Montelukast is used as a first line also for short duration. Is that right? See, Montelukast is always an add-on drug. Mild intermittent, mild persistent cases, Montelukast is not required. Because if the symptoms are for only few days, then plain antihistaminic is sufficient. When the patient is labeled as a moderate, intermittent, moderate, persistent, or severe allergies, there only montelukast is add-on, or even asthma also, where at the stage 3 level, there the montelukast is used as an add-on drug, not in the first line. Only thing is that as an allergist, the patient comes to us very late, so we don't have option because they have already been to many people. So we use as a first line, but not as a routinely. What will you see in the nose PNS in allergic rhinitis?
What see? Nose and PNS.
CT nose. Acha, CT nose. CT scan
CT
nose.
nose in if it is a plain allergic rhinitis, you just see many a times you may not see anything. It may be a regular nose. Sometimes you may see a hypertrophied inferior turbinates. I mean, many of the times hypertrophied inferior turbinates. As I said, mild, moderate, severe, and also in the nose only that much. Paranasal sinuses, yes, you can see a thickened. If it's a chronic allergy, you can see a thickened lining of the sinuses, and sometimes fluid collections. And if there is polyps, of course, if the in allergic rhinitis, if there is polyps, yes, we can see the polyps.
Thanks a lot, ma'am. Thank you, Michael. I think most of the questions have been covered now, and I don't see any further questions over here. That was a very good interaction by all of you delegates. Really, thank you, all of you,
Thank you so much.
because in allergy, most of the time, questions are very less, and only the speakers talk. So it was really, I mean, we also enjoyed it, and I also learned from your questions, and my thought process also started from today onwards more. Definitely, it will help all of us. Thank you, thanks a lot, and please share with your all friends and all. Few next webinars we'll be having more details on practical use of how the nasal sprays, which type of nasal sprays, how many days and all. Then we can have a case scenarios also, and definitely it will help in your day-to-day practice. Thank you. Thank you. Thanks a lot.
Thank you, sir. Thank you all.
Thank you.
Thank you, ma'am.